Good afternoon. My name is Matthew Clay, and I'm with JBS International. Thank you for joining us for today's webinar, Integrating Syphilis Programming into Behavioral Healthcare Settings. Before we begin, I'd like to review some housekeeping items. Due to the high number of participants on this call, all participant lines will be muted for the duration of this webinar session. If you have any comments or questions, please submit them at any time by using the Q&A window. To open your Q&A window, click on the Q&A icon that's located in the bottom center of your Zoom window. Closed captioning is also available. To turn on closed captioning, click the link that's located in the chat. If you experience any technical issues during the webinar, please message us using the chat feature, or you can email us at samhsa@jbsinternational.com. Lastly, this is a recorded event, and your participation grants consent to be recorded. The recorded webinar, along with PowerPoint slides, will be available and sent to participants at a later date. Next slide. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Substance Abuse and Mental Health Services Administration or the U.S. Department of Health and Human Services. Next slide. I'll now turn it to CSAT's Kristen Roja to get today's webinar started. Kristen, the floor is yours.
Hello, and thank you very much. My name is Kristen Roja, and I'm a public health advisor with SAMHSA. Today, I'll be doing a brief presentation on the SAMHSA's response to the syndemic of syphilis, mental illness, and substance use. Then I will turn it over to my colleagues from CDC, Fanta Dramé and Kate Mealy, who will be doing a presentation on the congenital syphilis crisis. We hope to have time for a Q&A at the end. Next slide, please. So first, let's talk about SAMHSA's response to syphilis and the resources we have for behavioral healthcare practitioners. Syphilis is a chronic bacterial sexually transmitted infection. The syphilis syndemic refers to the clustering of syphilis, congenital syphilis, substance use disorder, mental illness, and other STIs, including HIV, gonorrhea, and chlamydia. SAMHSA has issued a Dear Colleagues letter about the use of grant funds to address the syphilis syndemic. You will be receiving these slides after the presentation, but I will also drop in the chat links to these documents after my presentation. First, in January, we issued a Dear Colleagues letter indicating how SAMHSA grant funds can be used for syphilis. And then in May, we issued a Dear OTP Director letter that talks more about the role of OTPs in responding to this syndemic. For questions regarding the use of SAMHSA grant funds for syphilis, please email syphilisfaq@samhsa.hhs.gov. Next slide, please. First, here is a brief introduction to the Dear Colleagues letter that discusses the use of SAMHSA grant funds to address the syphilis syndemic. I've excerpted the paragraph that discusses this in detail, and it reads, unless expressly stated in your notice of funding opportunity through which your grant is funded, SAMHSA grant recipients are not permitted to directly use SAMHSA funds for the syphilis treatment. However, SAMHSA grant recipients may use their grant funds to address the syphilis endemic by providing syphilis and other STI screening, testing, and referral to treatment in conjunction with SAMHSA supported work. Additional allowable activities include, but are not limited to, training for staff, case management for people who test positive for STIs, service navigation for people served by SAMHSA grants to grant funds to syphilis or other STI prevention resources, and mental health support, and the development of memoranda of agreements with other a memoranda of understanding or other agreements with STI treatment providers. Next slide, please. Again, in May, we issued our Dear OTP Director letter, which discusses the role of opioid treatment programs in the response to the syphilis syndemic in more detail. Once again, though the link is on the slide, I've excerpted the most detailed paragraph, which reads, in addition to providing medications for opioid use disorder and other treatment and support services to address substance use and substance use disorders, OTPs are required to, quote, provide counseling on preventing exposure to and the transmission of human immunodeficiency virus, HIV, viral hepatitis, and STIs, either directly provide services and treatment or actively link treatment each patient admitted or readmitted to treatment who have received positive test results for these conditions. Next slide, please. Now I'm going to turn it over to Kate Mealy and Fanta Dramé, who will be talking us through the congenital syphilis crisis.
Thanks so much, Kristen. It's such a pleasure to be here. And thanks so much to everyone for joining us to talk about syphilis. I just want to acknowledge that your work is really, really hard, and that we are adding another really, really hard thing to your long list of things to do. And that, as Kristen said, is thinking about syphilis. So our hope today is that Fanta and I will be able to do a quick review of syphilis, and then we will walk you through the numbers of syphilis and then provide you with some resources so that you feel more equipped to deal with the congenital syphilis crisis in your settings. Next slide, please. Before I get started, similar to Kristen, I'll mention that these are the positions of both Fanta and myself and not necessarily those of CDC. I will add, however, that as federal government employees who talk a lot about syphilis, I want to recognize the importance of understanding the deep-rooted medical mistrust in the United States, in particular around syphilis. And many of you know about the U.S. Public Health Service study at Tuskegee, or the USPHS syphilis study at Tuskegee, which ran for 50 years in the United States and did not provide informed consent, nor did it provide treatment for syphilis, even after it was widely available. And I think in that context, we have to realize that, many people's lives were negatively impacted by this gross human rights violation. And today there are continue to be generations of people whose lives are impacted by that. So it's with that in mind that we want to move forward in talking about syphilis today. We also want to acknowledge a little bit about the language we're using in today's presentation. So as a reminder, race and ethnicity are real, but are social rather than biological constructs. So when Fanta and I are describing data that is based on race and ethnicity, or anything else about race and ethnicity, we're talking about the role of systemic racism and implicit bias, and not any physiologic differences in how syphilis works in the body. Of course, we also want to acknowledge that we are using the language of pregnant person and birthing parent to denote the person who is or was pregnant, and that when we use the term maternal, we're talking about features of a birthing person agnostic to gender and gender identity.
Yes, so thank you, Kate. So we have a few poll questions throughout this presentation. So actually, let's go back to the first slide, where people can scan the QR code, or you can join by web if you go to pollev.com/RobMcDonald667, or you can text RobMcDonald667 to 37607. So there's a few ways that you can join the poll everywhere. So we're just going to give it a few seconds just for people to get signed in. And it's anonymous, so you don't have to sign in with your name or anything. We just have a few poll questions just to get a sense of the audience, and just to make it interactive. So let us know if you have any questions or have trouble accessing the poll.
We're going to sit here for a second, wait for you guys to do it. So please join the poll. We're watching the numbers, and we're not going to move on until you guys have joined us. I think, Fanta, the easiest way to join is through that QRS code.
Yes.
Okay, perfect. I'm glad you agree. All right. Thank you. And if you want to click on the link is in the chat. All right, perfect. All right, so we'll go ahead and get started with our first question. So let's take a look at our numbers. So what's your position, role, title? So it looks like we have folks who are coming from throughout the SAMHSA space. No surprise here, we see lots of folks who are working in behavioral health, medical management specialists. So I think for a lot of you, a lot of DISs, we love the DISs. So the DIS, you guys are different. You know all about syphilis, but we're going to be more talking to the folks who don't consider yourself syphilis experts today. But I hope that everyone learned something new from today as we're moving forward. This is great. Thanks, everybody. All right, so we're going to go through Syphilis 101 with that in mind. We do, of course, have clinical images. You've been warned, as with any STI talk. So we'll go ahead and get started. So perfect. So just as a reminder, let's just get a sense. I want to make sure that we all understand kind of where we're coming to today as we're getting into the syphilis information. And as Fanta and I suspected, lots of folks are ready to learn. And I think all of my friends who are obstetrician gynecologists feel as though if they have access to the internet, they can get questions about syphilis right. And then some of you are syphilis experts out there. So if for the syphilis experts out there, I please invite you to go ahead and, feel free to pop in with additional information, additional thoughts that you have that you think might be helpful for the audience. We have about 95 people on the line. So please do, if you have any questions, use that Q&A feature, and Fanta and I will tag team to address your questions today. All right, perfect. So we'll go ahead. So this looks like it's going to be an overview for most of you, but we'll get into some more kind of syphilis 201 type content for the second half of the talk. But just to get us as a kind of level setting, I'll remind everyone that syphilis is a sexually transmitted infection, an STI, caused by the spirochete bacterium Treponema pallidum. It, of course, can lead to serious health problems without treatment, which is why we're all here today. An infection develops in stages: primary, secondary, latent, tertiary, and each stage has different signs and symptoms. It can be transmitted by direct contact with a syphilitic lesion during vaginal, anal, or oral sex, or transplacentally during pregnancy, which is why you have an OBGYN giving you this talks today. And very rarely it can be transmitted by touching infection lesions or through blood transfusions. The big complications that we worry about for untreated syphilis are neuro, so brain, ocular, eye, and oto, ear manifestations. And then, of course, for congenital syphilis, we worry about miscarriage, stillbirth, neonatal death. And what you might not know is that someone who has syphilis is at increased risk of acquiring HIV, and also is increased risk of transmitting HIV. So that's something else for us to keep in mind through our work together. And as I mentioned, we're going to go through the syphilis stages. Now, I know that they're really overwhelming. So for folks who don't consider yourselves experts yet, take a big breath. I want you to remember these three main points. So one, that syphilis goes through those three stages. And that the clinical stages and surveillance stages are different. So our DIS folks, you guys have a complicated job because you have to know both the clinical definitions and the surveillance definitions. And today we're going to be talking about the clinical stages. And the third most important point to remember is that neurosyphilis, ocular syphilis, and otosyphilis can happen at any stage of syphilis. And I think this is different from what a lot of us learned in school. So I just want to reinforce that point, that neurosyphilis, ocular syphilis, and otosyphilis can happen at any stage of syphilis. So if you're working with someone and they have syphilis of any stage, you need to be asking them about symptoms that might be consistent with those types of syphilis. All right, here come our clinical pictures. So we're going to go through these clinical stages. There's primary, secondary, and tertiary syphilis. And this primary syphilis, which is the classic pictures that we remember from any sort of schooling that we've done, is that, primary syphilis typically develops over about 3 weeks after infection and is characterized by one or more chancres or ulcers at the site of infection. And what we all learn in school is that chancres are typically painless and they heal spontaneously without treatment. But I want to really highlight that a chancre might be painful, and a painful lesion does not rule out syphilis, especially since chancres can be co-infected with HSV or herpes. And I'm seeing a lot more of that in my clinic right now. The picture on the left here is the classic image that we see in textbooks of a single penile chancre. The next picture is a labial chancre. And it's also important to remember that a chancre may occur in the vagina or other places that patients can't see. And since they might not be painful, a person might not ever know that they had a chancre. The next picture is a chancre on the tongue. And then this last picture is one of more than one chancre on the labia. And this is called a kissing lesion. And these can occur by either auto-inoculation from the syphilitic infection spreading from one site to another site, or from multiple sites of infection. And so that's what you're looking at there. So the takeaway here is that a chancre can be painful and you can have more than one of them. Now, this is secondary syphilis. Now, secondary syphilis usually occurs 3 to 6 weeks after primary syphilis. The most common symptoms of secondary syphilis are a skin rash, lymphadenopathy, and fever fatigue. The skin rash can be as subtle as that in the lower left-hand corner here and is classically on the soles of the feet or the palms of the hand, but not having these types of classic skin rashes does not rule out syphilis. And again, just like with primary syphilis, these symptoms will go away on their own without treatment. And I think for a lot of folks who I see, they never even have time to present for care. You know, they might have called and made the appointment, or maybe they thought about calling, or they thought about mentioning it when they went in to get their next refill of buprenorphine. But by the time they went to do it, the symptoms were gone and they never brought it up. And that's when patients go into latent syphilis. So latent syphilis are those stages of syphilis that are asymptomatic with no visible signs or symptoms. About 60 to 85% of people are asymptomatic for years without treatment. And then we divide latent syphilis into two buckets. So the first bucket is early latent syphilis, and that's latent syphilis that occurs less than 1 year since infection, and late latent syphilis that occurs more than 1 year since infection. But again, you know, it's often difficult to assess based on a patient's history, the duration of latent syphilis. And so we often end up declaring latent syphilis of unknown duration. And we're going to talk about the clinical implications of that in a minute. Now, it's important to remember that about 30% of untreated people with syphilis progress to tertiary syphilis in 5 to 30 years. And tertiary syphilis is that kind of classic syphilis that we do remember from school that is marked by the lesions of the cardiovascular system, usually the aorta, and the lesions of the bone and skin known as gummas. And so you can see here, this kind of on the right is this classic gumma of the nose. Now, for clinical purposes and also for how we think about treatment, we divide all of these syphilis stages into two really confusing big buckets. So the first bucket is this one that's marked by the purple box on the bottom here. This is the early syphilis bucket. So this includes primary, secondary, and early latent syphilis. These are the kind of the leading edge of the syphilis epidemic because these are the most infectious stages with the greatest potential for transmission. And then, as our experts in the room know, we treat early syphilis differently from how we treat late syphilis, which is our next bucket. And so late latent syphilis, as well as latent syphilis of unknown duration and tertiary syphilis, are dumped into this second bucket of late syphilis. And I want you to kind of think about this for a second. I think this is confusing. And before I became what I would call a syphilologist, I was really confused because early syphilis is in two places on this screen. And if you're new to syphilis or find syphilis confusion, I would take a screenshot of this slide because I find this slide really helpful. Fanta made it. Thank you, Fanta. And so I want to point out that this bucket of early syphilis on the left, and that is that bucket that we use to talk about differences in infectiousness as well as differences in treatment. But you also have early latent syphilis, which is another use of the word early, which again is confusing, but that early latent syphilis is dumped into that early syphilis bucket with primary and secondary syphilis, okay? And the other thing that's confusing about these two buckets is that we have the two latent groups divided between the two groups, which is also a challenge. So I just want to highlight that for you. So if syphilis, you know the syphilis has been around for less than a year and they have no signs or symptoms, it's that early bucket. And if it's been around for more than a year, it's that late bucket or unknown duration bucket. And it gets grouped in with tertiary syphilis for our treatment regimens, okay? Everyone still with me? Excellent. All right. And then lastly, next slide, please. I want to remind you again of that most important point, and we wanted to put this big on the bottom of this slide to just make sure that everyone is on the same page, that neurosyphilis, ocular syphilis, and otosyphilis can occur at any stage. And what this means for me as a clinician is that when I am looking at my inbox results, when they pop up in my Epic system, and I see that I have somebody who meets the diagnostic lab criteria for syphilis, I'm going to call them up and have them come right in so that I can see them again. And when they come in for their shot, I'm going to say to them, I'm going to make sure and see if they have any neuro, eye, or ear symptoms. And it's really important. And what I do in my clinical setting, which is probably going to be similar for most of you, because I assume most of you do not have an infectious disease clinician on hand at your sites, or you don't have somebody who can do a good thorough eye exam, like I certainly do not in my clinics. And if I'm worried at all, then I send that patient immediately to the emergency department. And I just want to acknowledge that that's really hard to do. And I know it's hard for our patients who have gone through a lot of hurdles to get to see me on that day, and then to ask them to do one more thing in the context of a really complicated life situation, usually for my patients, is hard. But I reinforce for them that if they do have ear syphilis, if I get them treatment today, then we can most likely reverse those symptoms that they have. But if it sticks around and holds on for too long, that can become irreversible hearing loss, irreversible vision changes, irreversible changes in how their neurologic system functions. And so I make that point really clearly with my patients when they're sitting there in front of me. Next slide, please. Okay, now we're going to talk about syphilis during pregnancy, which of course is my favorite thing to talk about. And so as you guys know, the reason that we're here is because we're really worried about those consequences of syphilis when it is acquired in a fetus, when a person who is pregnant has untreated or inadequately treated syphilis. And as we'd mentioned, syphilis during pregnancy is associated with miscarriages, stillbirths, preterm deliveries, and neonatal deaths. And of course, because we love to make things complicated in the world of syphilis, we have an early congenital syphilis diagnosis, and we have a late congenital syphilis diagnosis. And we also like to make things, a little confusing, because with the early latent syphilis and late latent syphilis, our divider between those two categories was 1 year. But when we're talking about congenital syphilis, our divider between the early congenital syphilis and the late congenital syphilis is 2 years. So I just want to highlight that for everyone so that you put it in your brains. So if left untreated, congenital syphilis can lead to serious complications, but most babies, when they're born with congenital syphilis, are completely asymptomatic, or they might have some constellation of these symptoms that you see here. So the hepatosplenomegaly, which is the big liver and or spleen, jaundice, rash, snuffles, and bone abnormalities. And everybody always says to me, Kate, all babies have a huge amount of nasal drainage. How does that differ from snuffles? And snuffles is just very different. So snuffles is a really intense, constant drainage. The reason for the snuffles is that if we were to take a specimen of those snuffles and put it under a microscope in the right conditions, you would see that it would just be swimming with those treponines, those little bacteria that cause syphilis. So it's a different ball game. And early congenital syphilis is diagnosed under 2 years of age. And then next slide. This is our late congenital syphilis, and this is when we diagnose it over the age of 2. And these changes are not reversible with treatment. These are permanent changes, and these include the classic Hutchinson's triad of complications with the eyes, deafness, and complications with the teeth. And so typically it's those Hutchinson's teeth and the mulberry molars. And then you can also see changes in the skull, including the classic saddle nose and some frontal bossing, changes in the long bones. This is like the typical saber shin that you might remember, and then developmental delays. And so this is why we're all here today, is because, we don't want stillbirths, we don't want neonatal deaths, we don't want tertiary syphilis, and we don't want late congenital syphilis. And then the other reason we're here today is that, congenital syphilis can be 100% prevented by diagnosing and treating syphilis prior to pregnancy, and by diagnosing and treating syphilis at least 30 days before a pregnancy outcome. And treatment of syphilis in pregnancy can treat fetal infection and prevent congenital syphilis. But I will say, when I think about everyone in the United States who works with us in the space of clinical medicine, as well in the space of public health, I think that you all are among the most important folks to help us think about the congenital syphilis crisis. Because in order to do these two things, in order to diagnose and treat syphilis prior to pregnancy, in order to diagnose and treat syphilis at least 30 days before a pregnancy outcome, we need to be reaching people outside of traditional prenatal care. And Fonsa and I are going to talk about that in a second, but I just want to acknowledge that without you all, we cannot do this, because we know that a lot of folks who are being missed in the prevention of congenital syphilis have lives that are complicated by substance use. All right, and then this is my last section, and then you get to hear from Fanta, who is more interesting than the content that I have. So we're going to talk a little bit about testing, diagnosis, and treatment. This is the really boring stuff, and I'm sorry. So kind of give yourself a little stretch. We're about 20 minutes into today's webinar, and we're going to go through this quickly. So there are two types of serologic or blood tests for syphilis. So one is a non-treponemal test, and these are in the left-hand column you see here. The other is the treponemal test, and those are the ones in the right-hand column that you see here. Now, non-treponemal tests, which are also known as lipodal antigen tests, are your RPRs, your VDRLs. They detect non-specific antibodies caused by inflammation. They are quantitative, measured in titers, and positive and active infection. Treponemal tests include the tests like the TPPA, your FTA-ABSs, your EIAs, and your CIAs, as well as the most recent rapid tests that we'll talk about in a second. So your treponemal tests detect antibodies that are specific to syphilis, but the most important thing on this slide is that those treponemal tests, usually your TPPAs, remain positive forever in about 85% of people. So what that means is that if I have somebody in front of me who I run a TPPA on, and they were previously treated for syphilis, about 85% of the time that test will remain positive, which makes it tough for me to know what to do with it. Next slide. And that's why you need both a non-treponemal test and a treponemal test to confirm a diagnosis of syphilis, because we need the non-treponemal test, which doesn't remain positive and is positive in active disease, but is a non-specific marker, and the treponemal test, which is a specific marker, but remains positive in about 85% of people forever. Next slide. And then to make this all even more confusing, we've recently had introduced to the market 2 FDA-approved point-of-care POC treponemal tests. So sometimes they're also called rapid tests. Ideally, anyone with point of care testing should also have lab-based testing. So these are the 2 ones that are currently on the market. I anticipate in the next few years that we're going to have a lot more of these tests. I also anticipate in the next few years we're going to also have the introduction of over-the-counter tests, so that are marketed directly to consumers. And so, we're going to continue to see more complications of syphilis, believe it or not. So this one on the left is called your syphilis health check. Yep. And then the other one is the ChemBio. And then we're going to compare the 2. Thank you, Fanta. So you can see that they're really pretty similar. So they're fast. They result in 10 to 15 minutes. They can sit on the shelf of your office for 24 to 30 months and still remain totally functional. And they're cheap. They're about $10. The sensitivity and specificity can wildly vary depending on the situations and what they're being performed in. And it depends on whether or not folks are well trained, what the environment is, and kind of, what the situation is. And that's why, in particular for the ChemBio, you see that wide sensitivity. I'll be honest with you, I don't think that ChemBio really functions any differently from syphilis health check. I just think that there were different types of studies that tested the ChemBio, which is why you see that wider sensitivity. But let's think about these sensitivity and specificity numbers together for a second. So what these are telling us is that the test picks up most, but not all syphilis. And that while most people who get these tests have syphilis, not all of them do. And the reason that these are important is, remember I said on the last slides that these point of care tests are just treponemal tests. And so what that means is they should not be used in anyone with previously treated syphilis. So I think we're in this kind of sweet window of time where a lot of people who are seeing you perhaps in the places where you provide care, and who are seeing me in the places where I provide care, perhaps have not been tested for syphilis in the past, and therefore have not been treated for syphilis in the past. And so I think in the next year or 2 that these tests will be really useful, because we're going to pick up new diagnoses of syphilis. We're going to get the results back in 10 to 15 minutes, and we can empirically treat based on these test results. But eventually, we're going to saturate the market in the next couple of years, and we will ultimately, I think, catch up with folks who have had syphilis, and we will treat them. And then when we get pops of positive on these tests, we aren't going to know if it's a new infection or if this is the people who are holding on, that 85% of people that stay positive for life. And so it's complicated. Next slide. And that's why it's important for us to remember that when we get these test results, that diagnosis and staging are based on more than just current test results. We have to think about the characteristics of the person in front of us. We have to think about previous syphilis treatment, physical exam, as well as signs and symptoms detected and described by the patient. If they say I had a chancre a couple of months ago, and it was pathognomonic, and they had a chancre in the past, of course, I'm going to be thinking, before they were treated for their last bout of syphilis, I'm going to be more likely to think about syphilis. And I want those prior and current test results. I'll be honest with you, I work in a situation where I almost never can find prior test results. That's so hard to do. And we need to get better systems. And that's what, Kristen and Fanta and I are working on at the national level, is to get you better systems so that you can see those prior test results. As our DIS on the line will tell you, it's just really hard to work without those prior test results. Next slide. And that's, because, we are seeing so much syphilis, we all need to be on board with screening for syphilis. And I think, this certainly includes all of you. So this slide, I encourage you to take a screenshot. This is the second slide in the deck that I would take a screenshot of, because I think it's a nice compilation of a lot of different information. And I just want to go through it slowly together, because I want us to be on the same page, because I think that you see patients who are in all of these buckets. And so you need to be aware of all these recommendations. I think you're some of the few folks in the country for whom that is the case. Sorry. So the first bucket in the top row in the left-hand corner, this is for people who are pregnant. They should be screened for syphilis 3 times every pregnancy. So we'll talk about this more in a second, but at the first prenatal care visit at 28 weeks, and anyone who delivers a stillborn infant, as well as at delivery. The second box is people who are sexually active, who are identified as men who have sex with men. If folks are sexually active, they should get screening for syphilis at least annually and every 3 to 6 months. If they're talking about certain characteristics such as multiple sex partners or anonymous sex partners. The next box on the top row is people living with HIV. And as I'm sure you know, they should be screened for syphilis at their first evaluation for HIV, and then at least annually. And that changes based on other characteristics of their lives. And then in the next row, for folks who are taking HIV PrEP, the guidelines indicate that they should be screened for syphilis at initiation and then every 3 to 6 months. And then for people in correctional facilities, universal opt-out screening, it should be done at intake. We say based on local area or institutional incidents. I just want to acknowledge that that's really hard to do in a correctional health setting, because people come from all across your state or your jurisdiction. And so it's hard to know your local incidents. And as Fanta's going to tell us in a minute, most people in the United States live in places where the syphilis prevalence is high enough that it makes sense to do universal opt-out at intake for in correctional facilities. And then the last box on the screen says sexually active and STI patients. So regardless of symptoms, screening of sexually active patients in most places in the country, as Fanta will tell you about in a second, and our folks with other STIs diagnosed should be screened for syphilis. And then, as I mentioned, these are the recommendations during pregnancy. So this changed in April of 2024. This came from ACOG, which is the National Medical Society for OBGYNs. And they said that all pregnant people should be tested for syphilis at least 3 times during every pregnancy. Next slide. And so, as we mentioned on the 2 slides ago, we said that all pregnant people should be tested for syphilis early in pregnancy. As a reminder, most states have a mandate for testing at least at the first prenatal care visit. And then, as we'll talk about in a second, we really think that we should be considering testing at the time of pregnancy confirmation if follow-up may be an issue. And I think this has implications for your work too. So, if you have somebody who's getting care through any of the work that you're doing, who is pregnant, who has not yet established prenatal care, this is somebody who we need to prioritize for syphilis testing and consider empiric syphilis treatment. And that is going to be really critical in our fight against congenital syphilis. Next slide. And as I mentioned, CDC recently put out somewhat confusing guidance about high prevalence definitions of syphilis. And so what we said plug your ears, my federal government colleagues, what we said in somewhat confusing CDC fashion is that counties with a primary and secondary syphilis rate above 4.6 per 100,000 among women of reproductive age should be doing additional syphilis screening among sexually active people. And what I will tell you is that, we've done the math, and this includes 76% of the US population. And, that is because so many of our counties have this higher rate, and most of our counties with a higher rate of syphilis have a higher population. And so my takeaway as someone who lives and works in Atlanta, Georgia, is that most people in the country should be getting that additional syphilis screening. And we're going to talk about ways for you to know the actual rates of syphilis in your community in a minute as well. Next slide. Now I'm going to quickly, in just 2 slides, go over syphilis treatment, because that is not the main focus of today's talk, but I didn't want to leave this incomplete. So for folks that fall into that left purple bucket on the clinical stage slide that we went through earlier, that early syphilis bucket that includes the primary, secondary, and early latent, they should be treated with penicillin G benzathine long-acting intramuscular injection. Just 1 dose of 2.4 million units is adequate. For folks who fit into that other purple bucket on the right-hand side of that prior slide, they fit into that late syphilis bucket, and they have either late or unknown duration syphilis, and they get 2.4 million units times 3 at 1-week intervals. Per our guidelines, those doses should be given exactly 7 days apart. In reality land where we live, that might not always be possible. And so our acceptable treatment interval, especially for people who are pregnant, is up to 9 days. And remember that the treatment must be initiated at least 30 days before delivery to prevent congenital syphilis. And then the other thing that I'll mention is that people who are pregnant who have a history of a penicillin allergy need to be desensitized and still treated with penicillin G. This is the only treatment that's been proven to be effective to treat those fetal infections and prevent congenital syphilis. Now, this is all with the caveat that we have been experiencing a big antibiotic shortage of extonsilline in the past year. I want to acknowledge that. It is our understanding in the federal government level that this is coming to an end. Very soon. It should be, I hope, declared. But we have moved to a place where it is our understanding that there is broad availability of benzathine penicillin G, and that you should be able to use that for your people who you see who are pregnant and who are not pregnant. So we had previously, when I gave this talk 2 months ago, I would have given you a slide about doxycycline and doxycycline doses. For those of you who live in places who are still having a hard time getting that benzathine penicillin G. But my understanding is that should not be impacting you at all now. And you should be able to be broadly using benzathine penicillin G. If you are not able to get the benzathine penicillin G, please let us know. Please let Pfizer know, and we will work to support you. I will say that, it's our understanding, so benzathine penicillin G comes in 2 doses. It comes in a 1.2, it comes in a couple of doses, but the 2 main doses for this purpose are 1.2 million units a dose and a 2.4 million unit dose. And so because everyone gets treated with a dose of 2.4 million units, they get 2 shots if they get the 1.2 dose. So they get 1 shot of the 1.2 in one butt cheek and 1 shot in the other butt cheek. And our understanding is that some folks are having trouble getting those 1.2s still, but everybody should be able to get the 2.4s. So if you know what I'm talking about, and you're not experiencing what I'm saying, please let me know, and we'll continue to do our parts and see if we can figure out what the delay is in your area. So now I'm going to go ahead and turn it over to Fanta, who will certainly be more entertaining in talking about syphilis trends, and then some more interesting topics to follow.
Thanks, Kate. So in recent years, the U.S. has seen a concerning increase in syphilis cases among women, as well as congenital syphilis cases. Compared to other perinatal infections such as HIV and hepatitis B, which have remained relatively low and stable, congenital syphilis has increased tremendously. So in the next few slides, we're going to take a closer look at those syphilis and congenital syphilis trends in the U.S. So as Kay showed earlier, syphilis presents itself in stages, and we collect information about all stages. But since primary and secondary syphilis are associated with recent infection, we use them to show where the disease is spreading. So this figure is showing that the rate of primary and secondary syphilis, how it increased by 222% over the last 10 years. So here, the lighter the color, the lower the rate, and the darker and bluer the color, the higher the rate. So as you look from left to right, you can see that the rates are increasing in all parts, and in the southern and western states are being more heavily impacted. So when we take a closer look by sex, men have historically had a higher rate of syphilis. However, during 2020 to 2022, the rate of primary and secondary syphilis rate among women increased by 190% compared to a 44% increase among men. So over the span of a decade, the rate of among women increased by more than 860%. And these increases in syphilis among women is especially concerning for congenital syphilis, as Kate mentioned. Then when we take a look at racial and ethnic disparities, non-Hispanic American Indian or Alaska Native persons and Black African American persons had the highest rates of primary and secondary syphilis in 2022. Since 2018, American Indian or Alaska Native persons also had the greatest 5-year rate increase with over 300% increase. To help illustrate just how high the rate of primary and secondary syphilis is among American Indian and Alaska Native population, the rate is nearly as high as the rate in the entire US population in 1946. So this is around the same time that penicillin was being introduced and mass produced. So you see that in 1946, there was a 70.9 cases per 100,000 compared to the 67 cases per 100,000 that were seen in the American Indian and Alaska Native population. So we're not quite there, but we're almost there. Another way to look at the racial and ethnic disparities is comparing the percentages of primary and secondary syphilis cases by race and Hispanic ethnicity due to the percentages of the total population of the United States in 2022. So we saw that the greatest absolute disparity was observed among non-Hispanic Black or African-American persons who represented 32% of the primary and secondary syphilis cases that we saw, despite being 13% of the US population. So because primary and secondary syphilis rates is increasing in women, there is a great concern from congenital syphilis, and then we're going to take a look at a few of those trends in the United States in the next few slides. So this figure here shows a striking relationship between the primary and secondary syphilis in women of reproductive age, shown by the black line, with the increasing rates in congenital syphilis cases shown in the blue boxes. So in 2022, there were 3,755 congenital syphilis cases reported. And during 2021 to 2022, this was a 31% increase. And then this was also a 1,000% increase over the past 10 years. So this is as you can see, it greatly increased, and it is following the trend of the primary and secondary syphilis rate for women. So this map helps shows where this is occurring. So similar to the prior map that shows the shifting rates in primary and secondary syphilis, in the span of a decade, congenital syphilis has increased across the country. So in 2013, there were 362 cases, which is still too many cases, but in 2022, there were over 3,700 cases. And unfortunately, as Kate mentioned before, congenital syphilis has many health consequences that includes infant deaths and stillbirths. And globally, congenital syphilis is the second leading cause of preventable stillbirths, but yet it is still increasing here in the United States. And in 2022, we had 51 infant deaths and 231 stillbirths. This slide shows both the rates of congenital syphilis cases, the length of the bars, and the number of congenital syphilis cases, which are shown by the numbers to the right of the bar, by race and ethnicity. The highest number of reported cases was among people who are non-Hispanic, Black, or African-American, highlighted in the gold box, followed by people who are Hispanic, Latino, and non-Hispanic white. This is the same graph, but this is looking at the rates of congenital syphilis in 2022. And the rates were highest among the people who identified as non-Hispanic, American Indian, or Alaska Native, followed by those who are non-Hispanic, Native Hawaiian, or other Pacific Islander, and then followed by those who are non-Hispanic, Black, or African American. And sometimes when we look at these rates, it can be confusing to actually grasp the significance of the rates and the gravity of the disparities. So we're showing the same data, but looking at it, the syphilis cases per live births in 2022. And those are the numbers that's shown on the right-hand side. So for example, for American Indian, Alaska Native birthing parents, there is one case of congenital syphilis for every 155 live births, compared to an Asian birthing parent who has one case of congenital syphilis for every 9,588 live births. So you see that wide disparity between the racial ethnic groups. So what's really troubling about these increases in congenital syphilis is that every case is preventable, as Kate mentioned earlier. So we looked at the congenital syphilis cases, looking at the timely testing and treatment during pregnancy. And doing the math, that we noticed that of the 3,755 cases that we have, almost 90% or 3,380 cases could have been prevented with timely testing and treatment. So then now we're gonna talk about the intersection between syphilis and substance use, and Kay's gonna go through that before we go through some strategies to address congenital syphilis.
Thanks so much, Fanta. All right, so it comes as no surprise to you that, people always want to understand the characteristics of people that are associated with syphilis. And what you can see is that this is a graph that's looking on the bottom axis at syphilis diagnosis over time, so from 2018 to 2022. And this is the percentage of people that are reporting any of these sexual behaviors and who have, and these are all people who have syphilis. And the most important thing about this graph that I want you to take away is that all of these lines are pretty flat, right? No one of these lines is going up astronomically. And what that tells us at CDC is that while there are high rates of association of sex with anonymous partners, sex while intoxicated or high, transactional sex among people with syphilis, we do not see increases in any one of these behaviors that leads us to believe that that is driving our current syphilis epidemic. And so that means that, we are just seeing more syphilis in general. Next slide, please. And this graph tells us very similar data. So this is specific among syphilis cases among people who are identified as women over that same time period. And you can see that these lines are also pretty flat. Now, we do see perhaps a slight increase from 2021 to 2022 of reported sex while intoxicated or high among women with syphilis. But we'll have to see over time if that is a true increase or if this is really just continuing to remain flat. But I know what you all, as people who work with people whose lives are complicated by substance use, are taking away from this is that there's somewhere between 30 to 40% of people are reporting sex while intoxicated or high among folks who have syphilis, and so that's telling you that you have a lot of folks who you're caring for who probably have syphilis. And then, so your next question, I assume, is going to be which substances are more commonly associated with syphilis? So this again is folks who have primary or secondary syphilis over the same time period from 2018 to 2022, and we're still seeing a leveling off. So there's no one particular substance nationally that's associated with our big increases in syphilis that we're seeing across the country. Now, I want to highlight something that I said in that last sentence, and I said nationally. So what you all are, I'm sure, thinking about is, in particular, my folks who are calling in from the West Coast, or folks who are calling in from other places in the country where you have a lot of meth, you know that there's a lot of meth associated with syphilis in your regions or in your communities. So this is what we're seeing in the national data. And so that does not mean that there are not local trends and characteristics that are different among people with syphilis. And so I just want to acknowledge that and say that it's important to know your local situation so that you can appropriately be reaching out to folks and getting them the services that they need around syphilis. Next slide. I wonder if oh, perfect. And then, what we also know is that punitive policies for substance use during pregnancy affect access to adequate prenatal care. And this is something that is, we really struggle with at CDC, and that I personally struggle with as a prenatal care provider in Atlanta, Georgia, who sees a lot of patients whose pregnancies are complicated by substance use. Is that, we see a lot of people who are coming in with late prenatal care and no prenatal care. And when we have asked folks about this specifically, they tell us that they are really worried about their children being taken away. And that fear of their children being taken away outweighs the fear of any poor health outcomes that might result as a result from having late or no prenatal care, which is really challenging, and something that I understand as both a clinician and as a parent, that those fears of having your child taken away are real. And so this is something that we're nationally looking at and that is being addressed on a jurisdictional level to change these punitive policies for substance use during prenatal care so that they don't become something that's a barrier to preventing people from seeking that prenatal care. And then such that they can get prenatal care, which of course also includes care for syphilis. But I just want to highlight before we move to the next slide that what this means for y'all in particular is that you might be the only people to see someone during their pregnancy. And it is of critical importance that we involve you in this fight against syphilis during pregnancy and congenital syphilis, because you might be the only healthcare part that these folks are interacting with. And so while we work at a national level and a jurisdictional level to address these policies, it's so amazing that you're all here to learn more about syphilis to be part of this fight with us. Next slide. And then, of course, you know that substance use impacts congenital syphilis outcomes and access to prenatal care. So this was an analysis that was done last year in 2023, specifically looking at cases of syphilis during pregnancy in Arizona and Georgia. And what they found is that people with a congenital syphilis outcome were nearly twice as likely to use substances during pregnancy as those without a congenital syphilis outcome. And the study found that people who were pregnant who used substances and delivered an infant with congenital syphilis, almost 40% did not receive prenatal care, and over half were not treated for syphilis during pregnancy. And so that, this really resonates with me, and it reminds me of how important it is for us to find other ways to reach people who are pregnant, whose lives are complicated by substance use with syphilis care. And so let's talk about our other challenges in addressing congenital syphilis, because there are many. Go ahead.
Thanks, Kate. So yes, along with the substance use challenges, when we talk about addressing congenital syphilis, we want to make sure that we're talking about it in a holistic approach that considers the individual circumstances and a broader social determinants of health. So factors such as poverty, limited access to healthcare, education, and unstable housing have significant impact on health outcomes. And the systemic barriers and institutionalized racism further exacerbates these disparities that we see. So for example, vulnerable populations may face competing priorities for basic needs. So they might be like thinking about where their next meal or where they're gonna sleep for the night, as opposed to thinking about where they're gonna get like syphilis testing or treatment or prenatal care. So this ultimately leads to the increased rates of infection among these groups. Additionally, as Kate mentioned earlier, we need to recognize and acknowledge the historical mistrust in the healthcare system stemming from traumatic events such as the Tuskegee and Guatemala experiments. And these events have, and others have deterred people from primary healthcare services. So when we talk about addressing congenital syphilis, it's not merely about treating cases, but also dismantling the inequitable systems and rebuilding the public's trust within the healthcare system so people can go and actually seek care and the culturally competent care that they need. Excuse me. So pregnancy care deserts also further complicates access to prenatal care. And these places that lack maternity care resources are places that lack maternity care resources, meaning there are no hospitals or clinics offering obstetric care. So this figure here was taken from the March of Dimes report on maternity care, and it shows that over 2.2 million women live in pregnancy care deserts. So essentially this means that there's no access to obstetric care. So imagine if people are not getting obstetric care, they're not getting, prenatal care, and they're more than likely are not getting syphilis testing and treatment services. This next graph here that you see is showing that more people are getting screened outside of STD clinics. So Kate briefly mentioned this, mentioning that people are not getting screened. People are not getting screened in STD clinics. People are not even showing up to their prenatal care appointments. So we need to think about how to show up or meet these populations where they are and make sure they have access to syphilis care and management. And we'll talk about this later more in the presentation about like strategies and where those places are to meet those individuals. And then lastly, we know that syphilis is complex, so we don't expect you to like understand it all and download it all in your brain. We just want to make sure like we want to just clearly mention that like syphilis can be preventable, and congenital syphilis is 100% preventable. And we know that it's complex because it prevents many significant challenges in testing and staging and its treatment due to its complex nature and also the inequitable systems that come into play. But there are strategies that we can all do together to help prevent this and, you know, keep baby lives and prevent stillbirths and infant deaths. So I'll pass it, before I pass it over to Kate, we just want to get a sense of what are some of the challenges that you're seeing with accessing prenatal care or syphilis testing and treatment, whether it's in your clinical spaces or within the communities that you see, or even in your day-to-day life. We want to hear those responses. And again, if you don't have access to the poll everywhere and you joined late, you can just join by web, pollev.com/RobMcDonald667. Or you can also, I believe, text Rob McDonald 667 to the number 2667. So stigma, payment for services, yes, that is something that we all often see as well. Transportation, getting people to their clinic and clinical appointments. Insurance.
Yeah, I mean, I think transportation really resonates with me, Fanta, when we think about those pregnancy care deserts. You know, in particular for people whose lives are impacted by substance use, you throw pregnancy care deserts on top of difficulty with transportation, on top of substance use. I mean, that is just, you know, so difficult. And I love this thumbs up feature of this polling software. Thank you. Yeah, we totally agree with all these. So we'll address these challenges. Thank you. Okay, so I know this is really daunting. I saw a couple of questions. We'll get to those at the end because I think those are separate conversations. So let's go ahead and dig into addressing congenital syphilis. Because we're CDC, we like to think about ways to think about addressing challenges. So this is kind of the puzzle pieces that we came up with that we think that you need to think about to address congenital syphilis. And we're going to go through each of these puzzle pieces on their own, but I just want to highlight them together so we all have the same framework. So the first is we need to be screening and treating sexually active people. The second is we need to be screening and treating people who are pregnant. The third is we need to be expanding screening in non-traditional venues, such as care for substance use. And the fourth is education, training, and surveillance. So you attending this webinar is part of that education portion of this as well. So let's hone in on that first piece of the puzzle. So we need to be screening and treating people who are sexually active. And so as I mentioned before, in most places in the country, if someone is sexually active, they should be getting a test for syphilis. So we're going to look in a second, and we'll share the QRS code with you so that you can know your local syphilis syphilis rates, and that so that you can be screening people for syphilis. And I will say that, you know, our guidelines also say that additional syphilis screening should occur for people who are at increased risk, which includes people who use substances. So, you know, almost everyone that you guys are probably working with who, if they're sexually active, meets the criteria for being screened for syphilis. And just because, you know, Fanta and I were talking about it, and we know that this, while you guys talk about highly stigmatized subject and you're very good at nuanced information, you're very good at working with people who are experiencing stigma. We know that comprehensive social and sexual histories might not be something that you've thought about in a minute. So we also are going to provide you with this link for NCSD, which is the National Coalition for Sexual Health Directors, really fabulous website on how to do that. And so, let me get to the question in the chat. Let me address this question in the chat first. So as there are some counties that are gray, and that is what someone in the chat, Courtney, has pointed out, is that is data that is unavailable. And in most of those places, it just means that by the time we put the final stamp on our 2022 data, they were having some problem with their national EPI systems. They had switched over to a new system, or there was some problem with their system such that they could not get us their final numbers in time. And we didn't want to hold up our 2022 data any longer to wait for them. So that's all that means. And that most of those jurisdictions, if you look back in prior years, they do have data. If you live in one of those jurisdictions and you are like, what is happening with my data? You can shoot me an email. And I'm putting my email into the chat, and I can get you the kind of unofficial numbers for your jurisdiction, or connect you with folks who have access to that data. So thanks for that great question, Courtney. Next slide. And then I just want to acknowledge that also as part of screening people who are sexually active, I think our new DoxyPEP guidance fits into this bucket. And so for those of you who do not sit in the STI space and who are not following the news, we had very hot information come out of the STI world a couple of weeks ago, and that there was a new recommendation for something called DoxyPEP. And DoxyPEP stands for doxycycline pre-exposure prophylaxis. And I think about this because I'm an OBGYN as the STI morning after pill. And what this is a new recommendation that clinicians discuss DoxyPEP with all gay, bisexual, and other men who have sex with men and transgender women with a history of at least one bacterial STI, so syphilis, chlamydia, or gonorrhea, in the last 12 months. And what DoxyPEP actually is just a prescription for self-administration of 200 milligrams of doxycycline within 72 hours of sex. Fonta just dropped the link into the chat. Oh, there it is. Yep. And you guys can read more about it there. We have another webinar that's coming up specifically about DoxyPEP that I'm sure our colleagues at SAMHSA will be sending you information about. And so if you're interested in learning more about that, you can go there. But I did want you to know about it because I think as you're starting to foray a little bit into the STI space, you might see people who say that they're taking DoxyPEP, have people ask you questions about DoxyPEP, or want to be proactive in preventing syphilis and chlamydia and gonorrhea by giving people DoxyPEP who meet this specific criteria. And then I'll add on the side, as someone who takes care of predominantly cisgender women, that the guidance does say that shared decision-making can be performed for patients who do not meet the criteria that are here on the slide. And that, you can talk about the lack of evidence and the potential risks for people who are not among this recommendation, but who are at really high risk of STIs. And then it might be appropriate to also offer them DoxyPEP. So for me, what that means is for my cisgender women patients, in particular, those who use substances and who engage in transactional sex, I do talk with them about DoxyPEP. Because I think that the risks associated with those STIs, in particular for my cisgender women patients, outweighs the possible poor outcomes associated with taking an extra doxy every once in a while. And I do see our question in the chat that I want to acknowledge before we move on. So with docs from Alicia. So with DoxyPEP being made available, would this make individuals more resistant to antibiotics if we're seeing more doxy out there? Which is a great question, something we're frankly really worried about and watching really carefully. We have seen, through some preliminary data, maybe teeny smidges of increased antibiotic resistance, but the reason that we feel comfortable making this recommendation at this point in time is because we are not seeing any changes that are clinically meaningful. But Alicia, we'll be carefully watching that data. And right now we think that the benefits of DoxyPEP outweigh those risks, which includes antibiotic resistance, but we're watching it very closely because that's literally what CDC does. And then, so our next piece of the puzzle, so that kind of lower left-hand corner that we saw in our puzzle pieces coming together, was screening and treating people who are pregnant. And so we already highlighted those new ACOG recommendations of screening at the first prenatal care visit, as well as at 28 weeks and at delivery, and also screening anyone who has a stillborn infant. We also know that we're prioritizing benzathine penicillin G for people who are pregnant, but that should, I hope not be an issue anymore. And then of course, we doing testing and treatment of people who are pregnant's partners. And so next slide, please. So this is just to remind you of that new guidance recommending 3 times every pregnancy screening. But then the next slide is reminding us that, people who are pregnant who might have a concern for loss of follow-up or who might not yet have connected with prenatal care, we should be thinking about those rapid point-of-care syphilis tests during pregnancy to identify and treat syphilis in one encounter. And this is where I think you all could potentially play a really big role, because we know that people, cisgender women in particular, and in particular cisgender women who are pregnant, that they're less likely than a lot of other populations to have previously been treated for syphilis. So they're a great population to be using those rapid point of care tests for, and then empirically treating based on the results of those point of care tests. And I just remind you that, when I went through the rapid point of care tests, I also said at the top of that slide that anyone who has a rapid point of care test should also have a serologic test. And so, ideally you would be in a situation, which you might be if you're sending hepatitis C testing, which is, predominantly done through a blood draw. What I would suggest is if you have someone who's not previously been treated for syphilis, who's pregnant, who's not connected with prenatal care, is that you collect the serologic test and you send that off per usual. That you also do a rapid point of care syphilis test. And if that comes back positive, that you go ahead and empirically treat that person for syphilis, while also, of course, connecting with prenatal care resources and following up the serologic test result. And then, if it's based on your conversation, you think that the patient needs those 3 shots, you would wait and only give the second and third shot if the serologic test confirms your diagnosis off of your rapid point of care test. And then we'll get to the other question from the chat in a minute. So next slide, please. Thanks, Fonta. And then our third part of our puzzle pieces was expanding screening in non-traditional venues. And so this includes, I think, a lot of the places where you see people. So what we are, using as our new tagline is, any healthcare encounter during pregnancy is an opportunity to prevent congenital syphilis. Any care during pregnancy is prenatal care. So, for both people who are pregnant and for people who are not pregnant, we need to be implementing routine screening wherever people seek care and receive services. So this includes a jail intake, in prisons and emergency departments, urgent care, syringe service programs, homeless shelters, MCH programs, birthing centers. And like I just mentioned, for anyone who might have a loss to follow-up concern, for people who are pregnant who have not yet established prenatal care, we need to be doing those rapid syphilis tests if they've not previously been treated for syphilis. Next slide. And then the fourth piece of the puzzle is, of course, education, training, and surveillance. So we need to be talking about syphilis, talking about healthy sex, talking about pregnancy, acknowledging that people who are pregnant have sex and that is okay and that is healthy. And we need to be, working with folks who are in any part of our healthcare system to help them to be able to screen, diagnose, and treat people with syphilis. And we need to be educating people who are pregnant about syphilis, educating the general public, and then any sort of resources that address fears for receiving prenatal care using substances. We need to really emphasize the importance of establishing prenatal care, and in particular getting care for syphilis. So I think that's where you all play a really important role. And then we just need to integrate syphilis and congenital syphilis education into your pre-existing programs and best practices. So this includes, equipping folks, everyone who's interacting with people in your community. So integrating syphilis screening into SSPs and other places where people who engage in substance use seek care. Leverage social media, set up mobile clinics, and use toolkits to meet folks, wherever they are. And in a second, I'll talk about a great resource to help you be able to do this. Because I'm sure, my guess is that I've sold you on the importance of integrating syphilis care into your settings, but now you're kind of like, oh, now what do I do? And I can help answer that question. Go ahead, Fonta. Oh no, let's go back to that slide. Where's that slide? The poll everywhere. Okay. So, but before we, we're going to share some resources, and I'm going to address Debbie's question. And while I'm addressing Debbie's question, we want you guys to tell us what you need. So what do you need from SAMHSA, and what do you need from CDC, and what do you need from the overall Health and Human Services to address syphilis and congenital syphilis? So while you guys are thinking about your answers, okay, great. Mandate. Yeah, I agree. We need to do a better job at making our guidelines clear, mandating testing, which I think helps to get funds. I will say that CDC is updating our overall STI treatment guidelines right now. So we should come out with clearer recommendations in 2025. But if you need more language, and if you're struggling with language to mandate testing for funding, let us know, and I can connect you with resources on that. And I agree, we need more jail intake testing. We need more education. Fonta and I are the queens of advocating for DIS funding. And I also acknowledge that it's kind of a slap in the face for all of our DIS colleagues, because we had recent budget cuts to DIS, and now we're asking you to do more. So we see you. We need more information in languages other than English. I agree. We are working on that. More education. This is great. Well, you guys can keep answering this question. We'll move on to our resources. And then Debbie, I'll address your question at the end. I see it. But so this is the information that Fanta and I promised you about kind of how to know your county's rate of syphilis. So I'm going to let you guys go ahead and scan that QRS code and go to that web address while I describe what it is. Thank you, Fanta, for dropping that into the chat. And so we will send you out this link as well in our follow-up email. And what this is a very cool resource. It's called the CDC STI Atlas. And I will acknowledge I'm not great with the QRS codes. And so whenever I want to pull this site up, Fanta, I just Google CDC STI Atlas and it pops up for me. And so what this allows you to do is to understand all of your different STIs in whatever jurisdiction you live in. So you can do it at the county level, at a state level, at a national level. You can cut the data by age, by race, ethnicity, by sex, by different kind of types of STIs, by different stages of syphilis, including congenital syphilis, to understand your exact situation. And as I mentioned, 76% of people in the United States live in a place that warrants really regular syphilis screening if they're sexually active. But this is a great way to find out exactly what your local syphilis situation is. This, of course, is our CDC STI treatment guidelines app. If you don't have it yet, it's free. It should work on any of your different smartphones. This will be updated in 2025, but that's not for a minute. So you should download it now. It's free. And as you can see from this picture here, it talks you through each infection, talks you through screening, how to take a sexual history, as well as giving you specific clinical tools about how to treat syphilis and other STIs. It's really a wonderful resource, if I do say so myself. And then this is a great resource that I have recently started touting, Kristen, and through the task force that we're both on together, that I learned about, is this Indian Country Echo Syphilis Resource Hub. And these are specific syphilis resources that are geared towards addressing congenital syphilis among people who are American Indian or Alaskan Native people. But I will say that it has phenomenal resources for anyone who's addressing syphilis and congenital syphilis across the United States. And I would never have thought to look here. So thank you, Fanta, for dropping that link in the chat. I highly encourage you to check it out. They have really great protocols if you're thinking about rolling out any new syphilis-related programs in the places where you work, including some great information about point of care testing. But there's also point of care testing information available through the new Health and Human Services considerations for the implementation of point of care syphilis tests. And so you can go to this link here, or Fonda's going to drop it into the chat. And then this also walks you through some really more protocolized thinking about what the heck to do with point of care tests, especially since the information that I provided today might have been confusing for you to think about how to actually implement it. And I think that guidance is pretty clear. I hope you feel the same. Okay, so this is our national network of STD clinical prevention training centers. So as you can see, there are 8 regional STD training centers across the country. I bet you can probably guess which one is the closest to wherever region you live and work and play is. But if you're unsure, you can go to this website and kind of look at the map and it'll tell you kind of which one is your STD training center. And if you need, say you want to do a syphilis talk in the place where you work and you need to find a subject matter expert to do that talk, you can ask these guys and they will find someone in your local area who has phenomenal SME, subject matter expertise in this area, who will do the talk for you for free, who might also know some things about your local jurisdiction, which I find really helpful. They can also help you think through your protocols as you're thinking about rolling out new syphilis strategies in your settings, and they can provide technical assistance on the subject matter expertise side. If you're thinking about ways to say you're going to roll out a new system where you're testing for syphilis at your center, and you need to find a way to easily communicate those test results to the local prenatal care clinic. They can help you think about ways, kind of data that prenatal care clinic would need, and to make sure that they're getting everything they need so you can kind of bridge their care to that other clinician. And so they're really phenomenal. The services they provide are free because they're paid for by CDC. And I just can't say enough really wonderful things about our STD training centers. And then next slide. We also have the National STD curriculum, which is also free. It gives you free continuing education credits. So if you have any level of learner, they can go onto this resource and use the different types of modules to learn about any of the STIs, especially syphilis. There's lots of different ways of interfacing with the curriculum, and so I find it works for any learner of any generation. You could say mandate a certain syphilis module for everyone who's working at your center. That might be a great way to kick off a new syphilis kind of strategy where you work. And then I think this is the last resource that we have today. So this is the STD-CCN, or STD Clinical Consultation Network. So if you're starting to care for people who have syphilis and you're feeling a little overwhelmed and you get those, crazy epic messages in your inbox and you're not sure what to do with them, you can reach out to these folks. They will respond in usually 1 to 2 business days. They say 1 to 5, but I've always found them to respond in 1 to 2 days. A clinician gets back to you and they say, well, based on that situation for this exact patient that you're describing in front of you, this is what you should do. And they're phenomenally nice and helpful. I will say also, as someone who cares for pregnant people, I will say that they're not afraid of pregnancy. So whenever I call kind of most clinical consultation services, the second I mention that the person I'm calling about is pregnant, they for some reason, the call gets dropped. And so, that will not happen with STD-CCN. If you are taking care of somebody whose life is complicated by, meth use and oxy, and they have syphilis and they're 32 weeks pregnant, they are psyched. They are ready to help you take care of that patient. So, they're a great resource. And then next slide. I think that takes us to the end. Oh, this is Fonda's phenomenal handout that she made that kind of blows my mind every time. So I strongly suggest that if you have any capacity to use QRS codes, you activate that capacity now and scan this QRS code. It will take you to this great PDF with these live links to all the resources we've talked about today, including many, many others. And Fanta dropped the link to the web link for it if you're not QRS savvy like I am not. You can listen to podcasts, you can watch webinars, you can just really get all sorts of different information that will be helpful for you regardless of kind of what you're thinking about in your work. And now I think we're ready for questions. Yes, thank you. All right, so let's go through some questions, Fanta, if that sounds good to you. I'm just gonna, since we're not overwhelmed by questions, I'm gonna go ahead and take them in turn. But the first question I want to take is actually the question from earlier in the chat, because I get this question all the time. Is what the heck do those titers mean? And how do you interpret them? So I will say that whoever the titer confused person is out there, you are not alone. And if you want to, you can go ahead and shoot me an email. I actually have a slide deck that walks us through titer management. I'm happy to send you those slides because I think it'll make it clear. But I'm going to try to describe in words what the titers are. So when I send off an RPR, it gives me back a result and it says reactive 1 to 4 titer. And then I get all confused, right? Because it's a 1 to 4. And if I think about that like a fraction, that's a 0.25. And a 0.25 feels like that's not a very high number. And then it just gets mussed up in my head. And so what you should do is think about them instead. Just think about them not as titers. Just think about the number itself. And the bigger the number on the bottom is, the more treponines that were in the specimen. And the way that we run titers in the lab is that we take the specimen. This is a kind of layperson's way of thinking about it. And I'm an OBGYN, and this is how I think about things. So they, drop the specimen onto the slide, and then they dilute the specimen. They dilute it. And depending on how many times I have to dilute it, so if I have to dilute it 4 times to make the treponines no longer visible, then that's, the number I get. So I've diluted it 4 times, so I'm going to say that their titer is 1 to 4. But if there are so many treponines that I have to keep diluting and diluting and diluting over and over and over again, that number of dilutions that I do is going to get bigger and bigger and bigger. And that number on the bottom is going to get bigger, which is because there were so many treponines, I had to dilute it so many times. So that's how I think about it. And if you think about the other question that I always get about titers is that, our guidance says that someone has been successfully treated for syphilis if they've had a 4-fold decrease in titer. And our guidance says that you should be worried about reinfection if somebody has a 4-fold increase in titer. And everyone is always like, Kate, what is 4-fold? So you know what my OBGYN trick is for knowing what 4-fold is just to divide the denominators. So if somebody's titer goes from 1 to 4 to 1 to 16, because 16 divided by 4 is 4, that's a 4-fold increase, okay? And if somebody's titer goes from 1 to 16 down to 1 to 4, that's a 16 divided by 4, that's a 4-fold decrease in the titer. So that person whose titer decreased by 4-fold, I would say they were successfully treated for syphilis, okay? And so that's how I think about it, but you're welcome to send me those slides. And then I would love to address this question about alcohol use. So something that you might not know, is that our national data on alcohol use is really crummy compared to our national data for other substances. And I would love to hear Kristen and our friends from SAMHSA talk about this, but I will say from a CDC perspective, our data on alcohol is usually worse than our data for any other substance. And that's because, you know, with alcohol, we get into this funny situation where societally and based on our cultural norms, we feel comfortable with a certain amount of alcohol use, but it's then when somebody crosses over to a certain level that we no longer feel comfortable. And so we have a hard time with our kind of surveillance data thinking about alcohol for that reason. So I can't answer your question with specific numbers, but absolutely alcohol use is, you know, associated with increased risk of STIs, and we know that it's associated with increased syphilis. If you would like specific alcohol data, I can send that to you, but I don't have it at my fingertips for that reason. And then I am gonna turf the Kristen, can I ask you to pop on the mic for a second? Because I love this question about pregnancy testing at substance use disorder sites, and whether y'all are able to pay for that or kind of how that works. And if you want to comment on the alcohol, please go ahead. You're more of an expert on this, on the data than I am.
I am actually going to see if Dr. Gandotra, who's also on the line, if you have comments about this. I'm researching the answer to your question regarding pregnancy tests. More information to come. And other than that, concur that it is, oh, I guess he is. Go ahead.
Hi, thank you for the question and also for wonderful insights from our CDC colleagues. I'll say that you're 100% right. Alcohol, in terms of being the elephant in the room, you know, half of all detoxification facilities, half of the patients are being treated for alcohol use disorder. We know it increases risk of contraction of many communicable diseases through risky behaviors. In addition to that, I can say that the data for alcohol use disorder that we get from NISDA reports it almost at, I believe, 20 million. I'll have to double check the exact number, but we have several individuals who are misusing alcohol every month. I would say anywhere from 13.1 to 21 million is the range that it's been over the past several years in terms of alcohol use disorder. But almost 50 million use it, have used it in the last month.
Perfect. And then I'll just ask you, do you, it sounds like, Kristen, you're going to get back to everyone about how folks can pay for pregnancy tests and whether that would be part of funding. If you, I will also add, Kristen, that if you guys want any help with that, I can connect you with the folks in the federal government who think about this from the maternal child health Title V lands. So just let me know, because that's a great question, y'all, and we need to be linking up those resources. And that's why we're so proud of ourselves for putting together a talk with both SAMHSA and CDC on the line. And we'll pull in our family planning colleagues as well. And then I'll go ahead and answer this question about the tribal lands. This is a great question. And so another kind of really interesting thing about surveillance data in the United States is that tribal land data is not part of our overall national data, because tribal lands are considered, you know, their own jurisdictions. And so there is poor information sharing between certain types of tribal lands and then other national kind of data epidemiology systems in the United States, which is kind of interesting from an ethical and political perspective. That we can have that conversation another day. But for our purposes, what that means is that sometimes those data end up being part of our overall national systems, and sometimes they don't. That said, our phenomenal colleagues in the Indian Health Service have done a great job figuring out different advanced strategies to get data for certain tribal communities who are not well represented in our national data. And so if you're interested in these data, I would love to connect you with my colleagues who think about this all the time and who are much more savvy about how you think about that. And then I'll go to Debbie's question, and this is about penicillin desensitization. This is a great question. So just to reinforce what Fanta and I said is that the only medication to treat someone who's pregnant for syphilis is penicillin. And that if somebody who is pregnant has a penicillin allergy, you have to desensitize them. And I will kind of hedge that and back that up a little bit, is before you do that, you need to make sure that it's a true penicillin allergy, because there's some really cool data out there that says that most people who report a penicillin allergy in the United States, when you actually ask them about their history and dig a little deeper and do testing, they do not actually have a true penicillin allergy. So you first want to confirm that it's a true penicillin allergy, and then you do the desensitization. And I would suggest that both of those processes involve people, getting on board people who are savvier at thinking about those things than I am. And so, depending on your setup, this is somebody, so if you have somebody who you're concerned for loss to follow-up and they're sitting in front of you and they say they have a true penicillin allergy and their empiric test set comes back positive for syphilis and they're pregnant, and they use substances, you're like, what am I supposed to do? And what you need to do is you need to get that person to go directly to the emergency department. And once they're in the emergency department, they will get someone on board who can perform the allergy testing, and then they will get them on board with the penicillin desensitization, which if they're over 22 weeks pregnant-ish, they will admit them up to labor and delivery and do that while they're on a fetal heart rate monitor, and it'll happen there. Debbie, I think the time frame, as you can tell from my answer, to avoid a delay in treatment is I just think you should need to just get them right over to the emergency department to get it to happen immediately. In particular, if they're pregnant, and in particular, if they're over 22 weeks, which is a viable pregnancy, because those penicillin desensitizations for people who are viably pregnant always happen in the hospital anyway, because people do them on the fetal monitors. At least I've never seen a different setup. I suppose it's possible. I hope that answers your question. And then another question is that, looking at the maps with higher rates, one can see that these often are tribal lands, but it would be good to have a map that indicates the counties and tribes. And you do understand the data sovereignty issue, but a map overlay would be useful. I assume this is the same person who's asking both questions. I totally agree with you. And our colleagues in IHS have those overlap maps, and I would be happy to connect them with you if you're interested in seeing that. That's a great point, and we should add that, Fanta, into how we think about putting these decks together. So thank you for that. I really appreciate that. Okay, and we have 3 minutes left, and it's possible that we have timed this out just right. Are there any more questions out there? Or maybe, Fanta, let's go to the next slide so we can get people to do the survey for our SAMHSA colleagues.
Thank you.
I'll turn this over to you, Matt. Yeah.
Thank you, Kate. Thank you, Kristen. Thank you, Fanta, for today's presentation. And just judging by the chat box and the questions, very engaging, and folks really got a lot out of it. So this concludes our question and answer portion. Just as a reminder, the recorded webinar and PowerPoint slides will be made available and sent to participants at a later date. Also, one quick note that all attendees will receive a link to complete a survey at the conclusion of today's webinar. So in just a moment, that survey link will be sent via Zoom directly to you, and it will be sent again 24 hours later. So we do just want to challenge folks to please complete the survey. The survey and the evaluation really helps shape future webinars. So with that said, just another big thank you to our presenters this afternoon. And as we close up for the day, wishing everyone a wonderful rest of your afternoon.